California monthly seminar. I think I know almost everybody here. I'm Rob McConnell. I'm the center director, and it's my pleasure to let Rima introduce our speaker for today. So, have at it.
Thank you very much, Rob. Thanks to everyone for being here. We're so excited. It's actually Megan Herting and I are co-hosting Dr. Stefania Papatheodorou, and we're so thrilled she's here. I hope to stay for the seminar and the meetings afterwards. But Dr. Papatheodorou is an associate professor in epidemiology at Rutgers School of Public Health, and she's also a trained obstetrician and gynecologist. Her research lies at the intersection of climate change, air pollution, pregnancy, and children's health. She has been the primary investigator on multiple epidemiological studies examining the association between prenatal exposure to climatic factors. You can sit up front, don't worry. Air pollutants and adverse pregnancy and childhood outcomes. Her research utilizes a wide range of administrative data sources, such as electronic health records, birth registries, and claims data. She's also the PI of an NIEHS-funded R1 that examines the effect of prenatal and early childhood exposure to climate factors and air pollutants on children's neurodevelopmental outcomes. So I hope you'll learn so much more from her directly in a few seconds, but I really hope you guys enjoy this because she brings together the epidemiological methods, the reproductive and neurodevelopmental focus, and she's also an NIH climate and health scholar. We're really thrilled she's here, so please enjoy and thank you so much.
So thank you, Rima, for this. Can everybody hear me? Okay.
So yeah.
For the kind introduction and for the invitation to be here today. I'm thrilled and I'm very excited to be amongst all of you today. This morning, I just met with your junior faculty and postdoctoral fellows, and it was a great experience as always. And thank you so much for coming here today for the seminar, which I hope you'll find useful. And the title is Inferences in Climate, Pregnancy, and Child Health, Traditional and Contemporary Issues. So what I want to do with this seminar is first give you an overview of our work up until today that has to do with air pollution exposure to air pollution, climatic factors, as I say, which is going to be both temperature, humidity, or other factors, and different childhood and pregnancy and childhood outcomes. But then after that, I want to discuss in, let's say, the second half of the talk, I want to discuss about a few epidemiologic problems that we had with the methods that we apply. And I want to frame this as, that has to do specifically with pregnancy being, as I say, a multi-state, putting pregnancy in a multi-state framework. So I will describe the common study designs, which I'm pretty sure you are all very well aware of when we are using to look at associations between time-varying exposures like air pollution, temperature, humidity, or other factors in pregnancy and child health. And then I'm going to discuss about pregnancy as a unique period to study time-varying exposures. We know that pregnancy is a very specific it has a very specific time framework in somebody's life, and it has certain characteristics which we're going to discuss about. And on top of that, we're trying to study different time-varying exposures, which has a whole array of issues associated with it. And then I'm going to discuss about different biases that can arise when we are looking at different data sources and what are the problems with these data sources, and different methods we are using for this climate change and pregnancy health, and then a few of the future directions to mitigate these problems. So I want to start by discussing about the difference between weather and climate. We are all saying we're doing climate change research and we are looking at the effects of climate change in different health outcomes, but I really think it's important to differentiate what climate change and climate means, because these are two different things. So the difference between climate change and climate itself is the time. So when we're talking about climate change, we're talking about long-term changes in climate. And when we're saying long-term, there is no like set threshold, but we're discussing for more than a decade at least. So for example, we hear stories that, you know, back in the days, our lake was frozen for several days a year. It's not happening anymore, but we are talking about like 30 years ago or 20 years ago. What we are actually studying in epidemiologic studies, most of them at least, is not climate change itself, but we are looking at how climate affects our health. And by looking at the short-term variability of climate and health outcomes, we do get some evidence about what the effects of climate change are going to be in the future. So I think it's really important to differentiate these two things. So I'm pretty sure you're all aware of the appropriate study designs to study the effects of, let's say, anything that has to do with air pollution or climate and pregnancy and childhood health. So we have our traditional cohort studies, prospective or retrospective. We have our time series studies, and we have a variation of the case control study, which is the case crossover study. And I'm going to give you a few examples of our recent work on these study designs. But if you want to look at factors that have to do with climate or air pollution and pregnancy outcomes, there are also different study designs that people have been using, such as quasi-experimental and experimental designs. And this might sound a little bit strange because environmental exposures cannot be randomized, right? So how can we have an experimental study? But you'll see we're using like the natural experiment approach to obtain this evidence. There are projection studies that are really tailored to look at climate change. So they're projecting how climate will change in the long-term future and how the health outcomes are going to change with these projections. And then we have even more complex studies that we have very few examples in the epidemiological literature, but they have been used like once or twice, which are the systems thinking and complex system methods. And we're going to discuss about those. So as an example of a traditional cohort study, we examined the effects of air pollution, climatic factors, and fetal growth. So we used the electronic health records of deliveries that happened at Beth Israel Deaconess Medical Center. It is a hospital in Boston from 2011 to 2016. We used all the electronic health records. So these were pregnancies that were expected to undergo routine ultrasound as part of the standard prenatal care at Beth Israel Deaconess Medical Center. And this is important. And me coming from Europe, where every individual has one ultrasound per month, here that does not happen. So people get one ultrasound for an early detection of anomalies, another for a more detailed anatomical ultrasound, and then the rest of the ultrasounds happen for fetal growth, but they do not necessarily happen if there is not a problem. So we have to think about those things when we are using these electronic health records to do studies. And we did have to do a few exclusions. So we did exclude multiple gestations, gestations that had only one growth ultrasound, let's say in late pregnancy, because these may be people that moved to Boston late in pregnancy. So we didn't really know about their history of exposure in early ultrasound, and the ones that had missing covariates, which were not a lot, but we'll go through them. For the air pollution and temperature data, we used well-validated models that have been used many times in the literature with very good performance and with very high resolution 1 by 1 kilometer grid for the whole United States, but we used the data for Boston, and for temperature, we used the data, the PRISM data that are in 800 meter grid, and we assigned these exposures based on the address at delivery of every individual. For the fetal growth measures, we used what is routinely used in every prenatal visit. So we get at least 3 measurements. 4 measurements, we get for the fetal brain, we get the biparietal diameter and head circumference. We get the abdominal circumference that mainly represents the accumulation of fat, especially in late pregnancy, and femur length that characterizes the length of the baby. We standardized everything using the intergrowth 21st standards for comparability with other studies. And we also looked at birth weight as an outcome, again, standardized by these intergrowth 21st standards. All the covariates, the models were adjusted mutually for the other exposures that we looked at. So the models for PM2.5 were adjusted for temperature and NO2, and the models for NO2 were adjusted for PM and temperature. We also adjusted for other covariates like maternal age, race, educational attainment, insurance type, parity, fetal sex, and humidity. And I do recognize that not all these are confounders. For example, fetal sex should not be a confounder, right? Because the exposure does not depend on the fetal sex, but it may be a very strong predictor of the outcome. So we did try the models with and without. There was no difference in the main effect, but we used it because it's a predictor of the outcome. And for the area level SCS studies, we used the area deprivation index at the census block group level. And this is a measure that uses 17 census variables, including income, education, employment, and housing quality. For our analysis, we used distributed lag linear and non-linear models. We also used general additive mixed models, and I will discuss about them as we move along. And these were adjusted also for the year of the birth and also for CISM and a random intercept for its pregnancy, because we might have multiple ultrasounds coming from one pregnancy. And this is our participant selection, starting from around 13,000 deliveries, excluding multiple gestations and non-Massachusetts residents, and then some other exclusions because of lack of ultrasound data, or people that had only one ultrasound in late pregnancy and missing covariates. We ended up in around 9,400 participants in our final sample. 51% of our participants were white. The mean age was around 31 years old. 48% had college or higher education. This is a map that shows the area deprivation index. With the blue, we see the least deprivation. With the red, we see the most deprivation. Our hospital is somewhere around here. So you can see that this is reflected in the mean ADI, which is 22. So these were areas that did not suffer from a lot of deprivation. And this is important to have in mind when we are interpreting our results. Also, this is the temporal trend of the PM2.5 levels. So we see that the levels went down, as we all know. But another thing that I want to point out here is that this study was performed in a very low pollution level environment. So again, the mean levels are below 10, remained below 10 for the whole study, and ended up being less than 7.5 for the whole study. So it is a pretty low pollution environment, so that we have that in mind when we interpret the results. So this is the first study. This is Michael Jung, who is the PhD student that led this work. And here what we see, we have the 4 different columns of biparietal diameter, head circumference, femur length, and abdominal circumference. And here we have, this is a distributed lag model, and here we have the different windows of the measurements. So measurements that happen 16 to 23 weeks of gestation, measurements that happen 24 to 31 weeks of gestation, and scans that happen 32 to 40 weeks of gestation. And what we see here for temperature is that biparietal diameter and head circumference, temperature had an association with smaller structures for biparietal diameter and head circumference. And we can see that this effect is sustained in mid and in late pregnancy. So exposure to higher temperatures in early pregnancy was associated with smaller biparietal diameter. The same was obvious in head circumference, but we see that this effect was not very obvious in late pregnancy. We see some effect in femur length, but not a very strong effect. That was not sustained in mid and late pregnancy, and some effect in abdominal circumference. So we do see a small effect here and some effect in the last in the late pregnancy scans. And we do see that associations with temperature, and this is something that we see a lot, is that with pregnancy outcomes, associations with temperature are mostly linear. They're not U-shaped, but this also has to do with the range of temperatures that we are looking at. You know, it's not a huge range of temperature, so we do not go very low in temperatures, and actually the mean temperature was 10 degrees Celsius. And these are the results for NO2, which is a traffic tracer, and these are the results for the biparietal diameter. Again, it's the same structure, distributed lag model with 0 to 40 weeks on the x-axis for the exposure. The 4 columns show the 4 different measures that we examined: biparietal diameter, head circumference, femur length, and abdominal circumference. And we do see that for NO2, things are a little bit different. So for NO2, we do see an effect in head circumference that is obviously later in pregnancy, not that early in pregnancy. So it's obvious in scans that happen mid to late pregnancy. There is some effect in femur length in mid-pregnancy, and there was no effect in abdominal circumference. These are the results for PM2.5 when we use an additive model. And for that, we have separated our scans into the 16-week scans, so the scans that are performed to examine anatomical abnormalities in the fetuses, and then the scans that happen afterwards, which show a more cumulative effect in fetal growth. So what we saw was that there was an effect of PM2.5 in biparietal diameter, and we have with the 3 different colors, we have the anatomic scans, as we say, and the growth scans that happen later in pregnancy, and at the end we have the birth weight. So we see that in this early pregnancy exposure had an effect in these anatomical scans that happen early in pregnancy. There was also an effect in abdominal circumference. That effect was sustained for biparietal diameter later in pregnancy, and again for the abdominal circumference that was measured later in pregnancy. And what I want to point out here is that if you see the birth effect, the birth weight estimates, in both cases they were mostly null. It has a point estimate of like in the lower side of the results, but if you focus only on the birth weight, you may miss all these like differential effects that pollution and climatic factors may have in the different structures that are being measured during pregnancy. And again, for the cumulative effect, we see an effect in biparietal diameter. We do not see, which is lost, but it's mainly because we average over a larger period of time. And since we've done this work, we want to see what happens if you take all these all these factors into account simultaneously. So we, this is the work of a master student that is graduating this May, and we applied the BKMR method to examine the effects of all these factors simultaneously. And we did see that, again, kind of the same message. So temperature was associated with smaller, these are the results for femur length, but these are more or less the same for the brain parameters and abdominal circumference. We did see a more uniform effect. So temperature was associated with the smaller parameters in early pregnancy, and we did try different things that I'm not showing here with the heat index and other more climate-related parameters, but we did see more or less the same results. We also performed studies using data from other parts of the world that are much warmer, like Cyprus. So this is the island of Cyprus. It is in the Mediterranean. The temperatures there are much higher than the US. The climate is pretty different. It's not only the temperature, but humidity values are different as well. So it's a lot different than the US. So we examined the effects of temperature variability, humidity, and humidity variability in birth weight. And here for this study, we used the birth registry data. So we captured the birth weight from what has been routinely reported in the Ministry of Health. So here we see, again, it's a distributed lag model, and here we see the changes in the birth weight in grams. And here we have the pregnancy duration, and we looked at pregnancies that we excluded preterm pregnancies, and we discussed about why we did that at the end. So these are the results for mean weekly humidity, 5 increase in percentage points in mean weekly humidity, and standard deviation of mean weekly humidity. There didn't seem to be an effect there, but we did see effects in weekly temperature. This is for 5-unit increase in weekly temperature. So we see an effect both in early pregnancy, but much more in the late pregnancy, which does make sense because at late pregnancy, we do have an exponential increase in fetal weight. So that may be the reason why we see a larger effect here. And we did not see any effect for the temperature variability by using the standard deviation. Regarding time series studies that I mentioned in the beginning, these studies usually looking at day-to-day variability of different factors like day-to-day changes in the PM 2.5 or temperature or humidity, and then how different the health outcomes vary by that. Now, for the time series studies, the good thing is that depending on the time scale you are examining, certain factors cannot introduce confounding. For example, we know that age of a participant is not going to change from the day-to-day changes in PM, or socioeconomic status is not going to change with, from day to day. We're not expecting these types of changes. So in time series studies, these factors are not of concern, which are of big concern in other study designs like cohort studies, right? So we use this time series framework to study the association between temperature and pregnancy loss. And we used a framework that is indirectly calculating pregnancy losses by counting the number of live birth identified conceptions for every week. So let's say you have a cohort starting from 2005, ending in 2006, and you have this number of live births here. So starting from these live births by week, we go back and calculate the conception date. And we create a time series, a weekly time series by counting, starting from conception date 0, week 0, and going up to conception week 40. And we count how many live birth identified conceptions we have. And in that way, we make an assumption that conception is not, because we're looking at post-conception exposures, so the exposures cannot affect how many conceptions happen. So any changes in the live birth identified conceptions are going to be due to pregnancy losses. So using this framework, we use the live births from 2014 to 2019 from the Cyprus Birth Registry. We had 55,000 eligible births that were analyzed, and we looked at different factors such as the daily temperature, the standard deviation of the daily temperature, the heat index. We also obtained data for NO2 that has been associated in the past with pregnancy losses. So, and it does change from day to day, so that may introduce confounding in our study design. And then we calculated the weekly average for all these and NO2 and created this time series. So these are the results of the study, like descriptives, only the number of live births, around 85 per week. Maximum temperature, the mean maximum temperature is 27. The mean minimum temperature is 14. The mean temperature is around 20. It's like double. In Boston, it would be 10. Here it's 20 degrees Celsius. This is all in Celsius. We do see large relative humidity and the other values as well. And this is what we found. We did see, this is again a distributed lag model, a non-linear model. So this is the risk ratio of live birth identified conception. So when we, it's a little bit indirect. So when we see a protective effect, we mean less live births, and then that means more losses. So we do see an effect in early pregnancy from 0, let's say, to 10 weeks. That is translated in around 0.97. It's a 3 to 4% decrease in the live birth identified conceptions. I know it seems low, but we do not expect larger values. It's not like a risk factor that is detrimental. This is the range of the estimates that we expect. And for the standard deviation, we see something different. So the temperature variability may be a factor that is associated later in pregnancy. And the other study design that I mentioned is the case crossover design, which has a lot of advantages. It is used mainly when we want to study if an exposure triggers an event. So it's very suitable for acute exposures and acute events. And so for this, we looked at the association between air pollution, temperature, and the risk of stillbirths. For that, we used the Medicaid analytic extract, which is, it's a cohort that is nested it's a national cohort for the US, and it's nested within the Medicaid data. Starting from 2000 to 2014, we had 120,000 stillbirth cases. This data is at the zip code level. We do not have addresses for these people. And we used PM2.5 and temperature from the previous models that I mentioned, which are a very high resolution, but we had to aggregate them in the zip code level. And we did this time stratified case crossover design. And the main principle is that if we have an event at a certain date, we match every individual with themselves on the same day of the month in the following weeks of the event. And by that, we take care of the seasonal compounding and the long-term compounding. So if you have an event here, you have 3 control cases. Depending when it happened, you may have 3 or 4, because something may be at the end of the month, so you can choose the previous 3, let's say Wednesdays or whatever day. And this is the work of Matt Shapler, who is a postdoctoral fellow working on this. And these are the results for temperature that we examined lags from 0 to 6 days. And here we have the risks of stillbirth. And we did not see much about temperature. So based on that, temperature does not seem to have a significant effect. And we did stratify by race. So here are the whole population. Here is for whites. For the Black population, Hispanic population, Asian and American Indian that we had available. But we did see an effect of PM2.5. So we did see that, especially in the Black population, we had higher risks associated with PM2.5. And it was basically it was not for the whole population, even though it's on the higher risk side, and almost nothing for the rest of the groups. I want to talk a little bit about the other study designs that we have not been using, but they are there in the literature, and I think they will be used more and more in the future. So one is the quasi-experimental and experimental design. So that involves any type of event that is outside of the researcher's control that can divide the population into the exposed and unexposed group. One such example are pregnancy outcomes in communities that were affected by some electrical grid failure that was associated with a cold spell, which is something that can be associated with climate change. And we compare them with an appropriate control group. So these are, we take advantage of these like natural experiments that happen from time to time. Now, the problem, as in any epidemiologic study of this type, is to select an appropriate control group. So some of them have the potential to suffer from selection bias. And there are different ways to approach this data. I'm pretty sure you've all heard the differences in difference design, where the pre and post intervention is available in the intervention and the control groups, which is more and more used in the literature, especially in climate change, not in pregnancy outcomes that much, but we do see reports that have to do with the heat warning systems and mortality, for example. But there are other ways that you can analyze this data, for example, by using what we call synthetic controls. So in epidemiology, we usually say that we need to get the controls from a certain group of people, and that has to be homogeneous. This can be a little bit different. So the synthetic controls can come from different sources of controls, which is a little bit more complicated, but it seems to work in some of the cases. Or methods that have to do with regression discontinuity. And that regression discontinuity concept is a concept that says, it's the same, you have to think about it in a sense that, let's say, we want to look at whether a drug is effective for hypertension. So we set up these thresholds and we say, people that have systolic blood pressure more than 140 will take the drug, people that have less will not take the drug. But essentially, who has 141 and 139 is the same. They don't have different characteristics. So we compare the results in that, like very close to that threshold to see if something is effective or not. So there are different ways to analyze this data. It's a design that gains more and more popularity in the climate and health literature. So it's definitely worth looking into it more. Now, the projection studies, which are actually studies that really look at climate change and not climatic factors, they involve projecting into the future different exposure-response relationships. And the main problem with the studies is the ability to take uncertainty into account. And it's not only the uncertainty in the climate, because usually you can look at different scenarios or different things that can happen, but uncertainty in the sense like how people adapt and all the other things that are associated with this adaptation. Do people use air condition? Is something that is going to happen more in the future, and how much more? So all these things are uncertain factors, and we know that possible future adaptations will likely moderate the exposure-response relationship. So that's something that is creating a lot of uncertainty in these projection studies. And then at the end, we have the system thinking and complex system methods. These studies want to comprehend the system as a whole instead of looking at temperature and preterm birth, temperature and birth weight. So like it's a whole different type of studies, and they are designed to look at very complex relationships at different levels, complex feedback loops, changes over time, nonlinear dynamics. And there are several ways to approach these studies, like systems dynamics, network analysis, or computational modeling. And that you have to think about this as how complex would it be to examine the effects of climate change as a whole with any pregnancy outcome as a whole, or different things as mental health. So if you look at the association at a higher level, you understand how difficult it is and how much narrow, like every single study that is looking at one factor and one outcome can be. And if that is addressing the whole problem or is looking at a little bit of a more general problem. So after having said all that, I want to focus on pregnancy as a period of life that we are all interested in, and present it as what I call like a multi-state, under a multi-state framework. So when you want to study pregnancy, you can have one of these 4 mutually exclusive pregnancy outcomes. So first, you can have failure to conceive. So it never happens, but you aim on having a pregnancy. So that is the first thing that needs to happen. You have to conceive. So that's the first conditional probability that you have to fulfill. And then you can have a pregnancy that will result in a clinical pregnancy loss, including both spontaneous abortion and stillbirths. And then after you fulfill this conditional probability, you have a pregnancy that may result in preterm birth, which is defined as a live birth occurring less than 37 weeks of gestation. And then if that doesn't happen, then you go to the next stage where you have a full-term pregnancy, which means that you have a live birth after 37 weeks of gestation. And you can conceptualize this as like a series of conditional probabilities that need to be fulfilled before you end up with your final outcome that you're studying. So first, you have a certain probability to conceive, and then you have a certain probability to have pregnancy loss, either early, late, stillbirth, miscarriage, whatever. And then if you don't have that, you have a certain probability to have a preterm birth, and then you have another probability to have a live birth. So this is what I call like a multi-state framework of pregnancy that needs to take into account all these probabilities before you end up examining this final preterm probability. And in real life, and in real data sets that we are examining, this is important because we have a data set with live births, and we want to examine the association between any exposure and a live birth and a preterm birth, let's say. And we ignore all the previous steps that happened before that. So we do not know if pollution or climatic factors are associated with pregnancy loss. We don't know if they are associated with stillbirths. We do not know anything about this. Sometimes we do, but we ignore it. And if you do that, you can end up with certain biases. So this is more or less something that we did. It's unrelated to climatic factors or air pollution, but it shows the multi-state framework that we have to follow when we think about certain outcomes and risk factors in general. So in this paper, we examined the association between, we looked at preeclampsia, risk factors for preeclampsia, but preeclampsia as an outcome, you have the diagnosis in your data set. But first of all, people need to reach the 20 weeks threshold to be eligible to be diagnosed with preeclampsia. So first, you have to survive long enough, and you have to reach the 20 weeks. And then you can either have preeclampsia, and you have a certain probability for that. And then with preeclampsia, at some point, you will deliver. So you can go from being to 20 weeks gestation to having preeclampsia, and then to deliver. And some people in your population will never be diagnosed with preeclampsia, so they will just deliver, right? So if you want to describe the whole population, you have to take into account all these probabilities. If you don't, and this is what we call the semi-competing risks framework, where one event competes the other. If you don't, you can say, okay, so I identify only two different possibilities. So you reach the 20 weeks threshold. So you survived long enough to be at 20 weeks of pregnancy, and then you have preeclampsia or you deliver. That ignores this middle probability over here that exists. Or if you see in the literature of preeclampsia, most of the risk prediction is like logistic regression, having, not having, and a bunch of risk factors, right? Very, it's very common. So that binary risk prediction is even worse because it goes only from 20 weeks gestation to developing preeclampsia without anything else in the middle. So after taking into account all this complexity, I think we need to pay attention to specific biases that arise if we ignore all these different multi-state frameworks that exist from conception to actually having a birth. So I'm going to discuss, and it's very relevant to environmental exposures, time-varying exposures, and when you use specific sources of data like birth registries. So one is fixed cohort bias. The second is selection of live births, conditioning on intermediates, which is a big discussion in our field, and different things that have to do with time-varying exposures. So this is a graph that describes what we call the fixed cohort bias. So let's say we want to examine the, we have a birth cohort starting from 2005, ending in 2006. And here with this like groups of 3, these are pregnancies that have the same conception date, but last for different periods. So here you have, these 3 pregnancies lasted, were conceived on the same date, but one pregnancy lasted for 19 weeks, and then there was a loss. Another was lasted for 21 weeks, and the other lasted for 42 weeks. So who is included in this cohort is going to depend on how long the pregnancy lasted. So what you get in your final sample, and when you're trying to evaluate time-varying exposures and different outcomes, that matters a lot. It can create significant bias. This happens in the beginning of pregnancy with shorter duration pregnancies being missed, and in the end of pregnancy with longer lasting pregnancies being missed as well. You're not going to have them in your data set because they gave birth after you finished your follow-up period. And this is an example that describes the association between temperature and, let's say, the risk of stillbirth. And we want to study this, and we have a data set that includes all the births from January 1st, 2001 until December 31st, 2001. So we have 1 year of data. And let's say we have 2 pregnancies that were conceived in June 2000. And we want to examine the association between temperature and the risk of stillbirth. Now, I think it's reasonable to think that some of the pregnancies that were conceived in June will end in stillbirth, and that the stillbirth duration, the duration of pregnancy in stillbirth is much shorter than the duration of pregnancy in live births. So let's say the median gestational age at stillbirth is 28 weeks in our data set and 38 weeks in our live births. So what will happen is that the stillbirths are going to be missed from our data set. So how does that affect our results? It depends on whether we had a very hot month of the June 2000 and what the true association is. So if we miss these pregnancies and there is some association, then that association will be towards the null. If there is no association and we have missed all the stillbirths, that may even go to the protective side. So showing that higher temperatures are associated with less stillbirths, right? So that is a function of bias, and we always have to think through how we are going to correct for this. The solution for this is simple when you have a long follow-up. So if you have 15 years of data, you analyze your data and then you exclude 9 months before the start, 9 months after, and you redo your analysis and see how the results change. If you have shorter periods, it may be difficult to do, but again, you have to have in mind that that may function in the study, that especially when you see a paradox. Another problem that arises, especially when we are looking at administrative databases, is the live birth bias. And what that describes is that we are doing our analysis taking into account only the live births. So we are not examining any, we are not taking into account the associations with miscarriages, with stillbirths. Sometimes it's all we can do because we do not have the data, right? So it's very hard to address analytically. It's almost impossible to address analytically. We can, if you have data on stillbirths, we may account for stillbirths as competing risks, but sometimes we don't even have good data on stillbirths. It functions in 2 ways. The first is a collider stratification bias type of collider stratification type of bias, and the second is this depletion of susceptibles. So collider stratification bias is that if you condition on a live birth, and there is a third factor that is associated both with your exposure and with your risk factor that you are examining. So by conditioning, you create an artificial association between your exposure and your outcome. The depletion of susceptibles is the concept that the people that would get your outcome, the fetuses that would get your outcome, are more susceptible in the effects of the factors that we are examining. So they are lost even before you can see the outcome happening. So these biases exist, and you have to acknowledge them always when you're writing, because the other problem is that they are very difficult to deal with analytically. It's not adjustment, there's not something you can really do about this, but you have to have that in mind. And sometimes they come up when we see paradoxes, like the birth weight paradox, or other paradoxes that we see in the literature. You have to remember that. And that takes me to the next bias that comes from conditioning on intermediates, and it's associated with the previous one. And this all started when many years ago, 2006, that was published. There was a paper published from Sonia Hernandez-Diaz about this birth weight paradox. And what this birth weight paradox said, they were looking at the association between smoking and infant mortality. So people were seeing that the association between smoking and mortality was in low birth weight infants, it was protective. Low birth weight infants had less chances of dying if the parent was a smoker. So that obviously was a paradox, and people were trying to think why we see this association. And that association was prevalent in this data set because they were conditioning on low birth weight, and the low birth weight may be an intermediate between smoking and mortality. And most of the times we say in the literature that, oh, we condition on an intermediate, so we take out some of the effect of, but it's not always like that. You can actually create collider stratification bias and see these paradoxes that arise. So it's not as simple as, okay, we see an association that may be even stronger if we do not adjust for it, but sometimes we introduce these biases by conditioning on intermediates. And this is very prevalent when we are doing pregnancy studies and we discuss about whether we should adjust for gestational age or not, right? That's always a problem. And we say we want to look at the association between temperature and birth weight. And should we or should we not adjust for gestational age? There is no straightforward answer to that. Like most people, I think now are against adjusting for gestational age, especially when there is an association between your exposure and duration of gestation in your data set. So at least we should address this probability that that may not be the optimal way to adjust for our confounders in our model. So we should try several other sensitivity alternative analysis before we end up saying that there is an association or there is no association, or we can look at our data set and if there is no association, because this is not a uniform association with any kind of environmental exposures and preterm birth. So we just have to have that in mind before adjusting or not adjusting for gestational age. And another important thing that I want to point out is race and ethnicity as a confounder. So it is, I mean, I do not have to say a lot about this. We consistently see worse outcomes in the Black population versus the white population, but it's because they are exposed to all these different, here is a vulnerability score for physical environment, for socioeconomic determinants, or for physical health. So it is very important, like we see that all the time, that people just automatically introduce race in their analysis and say, we adjusted for race, but we really have to think about what do we expect and what do we say when we want to adjust for race? Are we expecting that there is a biological way why the results, the effects may be different? Certainly not. It's because all these other factors that the people are exposed to that make them more vulnerable to worse health effects. So instead of just naively introducing race into any analysis, we should definitely pay attention on what we mean and what we want to achieve by this adjustment. And the least we can do is just stratify and make sure we show the results for every race group and be very clear about why we think the results are looking the way we do. So it's not a nice strategy to just introduce race as a confounder and name it as a confounder in our analysis, just like naively like this. And at the end, I want to discuss about this immortal time bias, which is very difficult to deal with. This is an example of a very well-known demonstration of this bias, which has to do with if gestational diabetes is a risk factor for stillbirths. That has been, it's a very important question, and people have been trying to address this. And it goes back to the same thing that I said, that you have like gestational diabetes screening happens at 24 to 26 weeks of pregnancy. So to be diagnosed with diabetes, it means that you have survived long enough to reach that level, to reach that gestational age. If you ignore the previous time that you spent up until the diagnosis of diabetes, and you do not count that as unexposed time, then you can see all these paradoxes that we can see in the literature. So right now there is a lot of work happening with these like target trial approaches, where you try to align time zero for exposed and for the non-exposed, and analyze all observational data as if they come from a randomized trial. What would you like to see in a randomized trial? So there are more complicated approaches to address this issue. The least we should do is align the time zero for both, exposed and unexposed people, and count the time appropriately, because otherwise this will become immortal time and will end up in weird results. And I want to take a few minutes discussing about these distributed lag models that I mentioned in the beginning that are very popular. And this is how we analyze the pregnancy data most of the times. It is a popular method to estimate the association between an exposure that is observed longitudinally and things that happen during pregnancy and birth, and even childhood outcomes. And they do have the ability to simultaneously estimate these exposure-response relationships at different time points. So this is a very simple example of weeks of gestation from 0 to 40 and a relative risk, and we see this line like coming up and down, and with a 95% confidence intervals. The good thing is that the distributed lag models can be applied with different resolutions of data. So you can have data at the zip code level, at the address level, from one monitor, from multiple monitors, or any kind of exposure data. We have to have in mind that low or no spatial resolution in the exposure data that include like individual level analysis. If we use data coming from, let's say, a single monitor or weather station, it may be problematic and it may provide weird results because of this misalignment of the detailed exposure, the detailed health data and exposure data. And also we have to be careful in studies that are looking at rare outcomes, because we would require to aggregate the data to a larger spatial unit, have a sufficient number of outcomes, and this can create misalignment in the definitions of the exposures and the different elements that come into the distributed lag models. Sometimes we have what we call the bias amplification. It's known as Z bias because Z is the letter that is used for the instrumental variables in epidemiology. So this is why we call this, when you use any kind of instrumental variable to describe anything. So you can have this Z bias if you have residual confounding by these time trends. If you have multiple factors in a distributed lag model, we have temperature and PM 2.5 and NO2. Many issues can arise, but what we call concurvity, it's the same as multicollinearity in a linear model. So it's the same thing. We have to be very careful about what we put in the distributed lag model. And another thing that I want to highlight is that we have to think about what they show, because we do have 40 tests at the same time, and there is no causal inference component in the distributed lag model. So what you see is the result of 40 simultaneous tests for the same exposure and for the same outcome. So some of the effects that we see, especially if we see only one small window in 1 week, may be a function of chance rather than a true finding. So we have to be careful about the interpretation. So I hope I didn't tire you a lot. So after having all this said, I think that we need to acknowledge that there is extreme attrition between conception and birth. And it's important, to the extent that we can with our data sets, to take into account this attrition that happens with competing risks or other approaches. pregnancy duration is delimited, so we have to think when we have a very fixed time frame that we identify our cohort, what happens with the pregnancies that didn't make it to the time frame, and what happens with the pregnancies that will give birth after the end of our study. When we are looking, when we're looking at mother-child pairs, it adds another level of complexity. Everything that we said so far goes beyond in what happens to a child. And when they move and the years go by and other exposures happen, are we able to account for this as well? So it is even more complicated when we go to mother-child pairs. It is a very, this field as a whole is challenging, and some of the approaches we use that are great for visualization and provide mostly valid results may suffer from limited causal inference. So we have to be careful about the interpretation. And we have to acknowledge that observational studies will always have some limitations. So it's better if we acknowledge them. If we can do something about them, we should. If we cannot, we should acknowledge the potential for bias or try to quantify if how much bias we can get, but at least say something about it. So I want to thank you for being here, and I would be very happy to answer any questions. Hope I didn't scare you with all these limitations. I'm sorry.
And maybe we'll give people 2 seconds to think. Just in case we run out of time, because I know that will happen. At 2 p.m. upstairs in GP2, we are having a maternal and fetal health discussion with Dr. Papatheodorou, and then at 3 p.m. a neurodevelopmental impact discussion led by Megan here. And then at 4 p.m. climate and health. So please keep the questions coming and the discussion. Yeah.
And I cannot say that the studies that were performed by me or others are like perfect. They are all subjected to all these biases. And we're always concerned and try to find ways we can, for example, I'm working a lot with the claims data, and it's hard for people to realize that this claims data research is not like you have this huge data set sitting somewhere and you can, answer all the questions you can get, because every time you want to look at something else, you have to recreate a new cohort. So for example, if we want to look at the effects of stillbirths, we have to go back to the original data set and add this population. It's very complicated. So it takes a lot, but at least we're trying to address those issues. And the other thing is that you are only worried when you see a paradox. So when you see a paradox, that scares me, because when you see that everything makes perfect sense, it may make perfect sense, but it may be very wrong. So when you do not see an alarming result and everything flows well, it's more dangerous than, because when you see a paradox, you start thinking, how can we address this? Let's see about this, look at this, let's look at that. But if you don't, and everything makes perfect sense, this is the scenario that I'm very worried about, because, you never know what can function.
I'm curious what the proposed mechanism is from temperature to the health and vitality of the fetus. Is it considered maybe a stress on the mother's system, or kind of how does temperature affect the fetus?
So that's a great question. And there are general mechanisms functioning dehydration, and that can lead to inflammation and oxidative stress. But thermoregulation in pregnancy is not as efficient as in non-pregnancy period. So thermoregulation as a mechanism in pregnancy is affected by pregnancy itself. So it's harder to keep the homeostasis of the temperature regulation in pregnant individuals.
Thank you.
I can tell you. Okay, go ahead. We're sorry, Jill, then Aaron.
I have a question about your results. I think your first set of DNLM results that you had, just to help understand them, because you had whether the scans were done, I think it was 16.
Do you want me to go back?
If you go to the slides,
Yes.
that'd be helpful. Kind of the earlier, the midpoint, and a little bit later. And I think most of them were linear, except for one of them was non-linear. And so I'm assuming that meant when you were going through it, the knot placement was having one no knot or whatever. The linear effect was going to be the best.
You mean this one?
Yes.
So the effective degrees of freedom were close to 1 in all of them. So it was mostly linear, which I see more often than I would expect in pregnancy, especially with temperature. And we always get this comment from reviewers that, but we see linear associations. I don't know, like, it's not the same as, let's say, with mortality, because you do have this U-shaped association with mortality, with both low temperatures and high temperatures increasing the risk. We do not really see that in pregnancy. I don't know. That's why I'm so interested to see data from other populations, because maybe the range is not that. We're looking at the one part of the distribution where it is indeed, it may be linear.
Yeah.
So we don't have like very low temperatures.
Yeah, and I guess I'm thinking about how to think about these three, so going horizontally down, thinking about the 3 time points, which in trying to interpret the result, is it correct to think that like the first, like the top row, 16 to 31 weeks scan, that is kind of essentially a subset of what might have happened like in the bottom row. Like I'm trying to think of how do I compare across the different scan time points.
Great. So we have 3, these are scans that happen early in pregnancy. These are scans that happen in mid-pregnancy, and these are scans that are happening in the late pregnancy. Now, one thing, I'll finish this and then I will mention something else. So this is the exposure from 0 to 40 weeks. So this is how the results look like with early exposure in these scans. So early exposure keeps, sustains an effect in later scans. So you measure the biparietal diameter in, let's say, week 35, and because of the early exposure, you still see a decreased measure. That is obvious even from early measurements. So here you measure biparietal diameter in 16 to 23 weeks, and the early exposure has this effect. It reduces when, as time goes by, it becomes less, but it's still there.
So if you have some outcomes that, like if you think about trajectory of some of these measures within in utero over time, you might have some reduction earlier on, but some recovery later, so that by the time you look at it here, maybe you don't see an effect. But when you see it earlier, you do, or you might have a sustained.
Yes.
Okay, great. Thank you.
The problem why we could not do trajectories is that most of our population had 2 scans. So we were not able, and you have to remember that people that have more than 2 are more likely to be high-risk pregnancies. We did see whether, the number of scans was not associated with the exposures. So we were not worried about selection bias, because for selection bias to function, you need to have something that is associated both with the exposures and with the outcome. They're definitely associated with the outcome, but the distribution of pollution and temperature was the same. So there was not, we were not worried about selection bias, but the results here may be interpretable only in these high-risk pregnancies. It's hard to generalize because of this peculiarity, because we used electronic health records. So we use the data that are there collected routinely for all pregnancies. It's not a cohort that was designed to look at these outcomes.
Yeah, my question was you sort of touched on it, but thinking about some of your national data, do you see regional specific effects or effects based on what, temperature variability normally is, and how do you think through that?
So this is great question. We are currently doing, so my current funding, because we saw these effects with fetal brain, but we do not know if they have a clinical interpretation. It may mean nothing. So we want to see if these exposures during pregnancy are associated with, developmental delays. The other problem is that, for example, with autism, larger may be bad as well, not a good sign as well. So in people with autism, some of the structures are actually larger, not smaller. So that all these issues are valid here. So in the national studies for neurodevelopment, we introduce state in the model, and we cluster by zip code, because all the zip code related observations are, connected to each other. We do adjust by, we introduce state in the model for 2 reasons, because there may be these regional differences. The second is that because the diagnosis of neurodevelopmental delays and the systems that exist are different by state. So the other problem, so this is how we address it. I do not have results because we're currently doing this analysis. But one thing that we need to be careful about is that we avoid reporting results by region when we do these national studies, because there are a lot of issues with confidentiality. We cannot focus on any specific region because then we will, it increases the potential for identifying people, and we're not allowed to do that. So we don't usually say like, oh, this area of the US has higher risks. The other thing is that because we have this national data, it's hard to distinguish which is a true finding. Like you have all these different, it depends on your, spatial resolution and what you're looking at. So, but in general, we do some analysis by area, but not very granular.
So do you look at heterogeneity by different regions for your, I mean, if you could certainly report that we looked at region specific and we don't see any heterogeneity.
You mean the regions in the 5 regions of the US in general?
Or even more granular.
We do, but we do avoid doing like the granular. We may report by state, like, overall in the state level. We are not usually doing like a more granular report. And this is something that we are prohibited also by the people that give us the data. They do not want us to report, we can report by race, or we cannot report like specific location because it increases. This is a more general issue with the data science, because even if you strip all the identifiers, you have no identifier in your data set. The fact that you have 50 area level daily values, you can identify the people, which is, it's a threat that is happening more and more. The more variables we gain, the more granular our data sets. So even if you do not have any identifiers, the fact that for any individual you have an array of values, that may increase the potential for identification, and they are very careful about that.
Does anyone else have questions? I have one, but I want to make sure you guys can. Yeah,
To clarify consider the controversy between gestational age, including gestational age, that would be really well. Could you elaborate on that a little bit?
Yes, so in any perinatal research, and when you're looking at the effects of like any environmental exposure or time varying exposure and an outcome, so there is an issue that exists when your time that you're exposed is tied to the gestational age. So if you are looking at the effect of PM 2.5 and preterm birth, if you do the naive analysis, that probably is biased, because the more the duration of the pregnancy, the more exposed you get. By definition, that's how it is structured. So we need to find ways to disentangle this association with the time varying exposure and the time varying outcome that are associated by definition. We do use more advanced, if you want to look at that specifically, we're using, let's say, G computation that actually disentangle the association between the duration of pregnancy, the definition between the duration of pregnancy. So you create a scenario where you say, like, what if everybody was exposed and what if nobody was exposed? And then you compare the risks. In other scenarios, when you're looking at any kind of association, let's say temperature and birth weight, and you are, your question is whether we should adjust for gestational age or not, because we know that any environmental factor, most environmental factors are associated with gestational age, and gestational age is associated with birth weight, right? So if you adjust for gestational age, the first thing that happens is that you may take out some of the effect of the exposure, which is not the worst thing that can happen, but you can actually create a paradox that may show that in preterm births, higher temperatures are better. And you don't make sense, that doesn't make sense. If you have a hypothesis that says that temperature reduces, of course, we try not to be like as strict in our hypothesis, but if you think that it has a harmful effect, you may suddenly see that temperature is very beneficial for preterm births. Or pollution is very beneficial for something. Then you have to think that there's something going on here. Sometimes it's just adjusting for this intermediate. So it's not as naive as many people say that, oh, okay, so if there is an association, it's an even stronger one. It's not that simple because you can actually create a paradox that says that pollution is good for you. Pollution produces, and it's not like sometimes pollution has been associated with larger birth weight because it's associated with diabetes. So it's more complicated. It's a complicated thing, but especially when we see things that don't make sense, like let's say pollution is protective against autism. That cannot be true, right? Like it may be null, yes, it may not be, but protective. So then that's why when I'm actually feel safer when I see these paradoxes, because you may not see these paradoxes and the analysis may still be wrong.
Go ahead.
I think you've heard 2000 Davies that reference this, and there's a Wilcox paper out there as well. Right?
Yeah.
That's on that. Why do you think this still be a thing? Why haven't? Because I had a paper just recently, and then two different reviewers wanted two different things. One wanted to say just before, the other one said decline. And so like, how do I go about fixing both of those about trying to get it through in the couple of running into that? So I was having to think like, do you preempt this in all the papers that you write with this? Are you preempting to why you didn't? Because I've tried that and I still run into it every time. People seem to be very set in their ways of whether they want it or not.
So no matter how, well established knowledge, this is, this was the Wilcox paper, then the Hernandez Diaz paper, and several other papers after that. Like there is the obesity paradox with Maria Glimmer that it says like, obesity is protective, like in mortality. So you should gain weight. So all this, so there is like some awareness of these paradoxes that can happen. Now, in perinatal literature, it's not. It's a better established knowledge, but it's not like there is no consensus on what you should do about this. And the other issue is that many times the papers are being reviewed by non-epidemiologists. And intuitively, it makes sense to adjust for gestational age. Like intuitively, like if you ask any clinician, do you think that gestational age is, they'll say yes, of course. So it's hard to conceptually disentangle this complex association. What I do in my papers is first I try to see if there is an association between my exposure and gestational duration. I try to discuss this upfront. So I say like, because gestational age may be an intermediate, we check this X, Y, Z. We did not find an association, so we are not expecting this bias. So you acknowledge the fact that there is an issue, and then you depending on how the associations look like in your paper, you may or may not want to. Now, if you're interested, so if there are no paradoxes, sometimes, most of the times there is not such strong association that creates a paradox. So you may actually be interested on what is the effect of your exposure to your outcome directly and indirectly. If that's the question, you should employ mediation analysis. So that's a kind of like a different question, but it all depends on what you want to answer. If you want to answer if the effect of the exposure is mediated through gestational age, so we should make sure that there is no preterm birth, and if there is no direct effect, then it's different. But you should say something about it, like try to address it somehow, because you go to this discussion with the reviewers back and forth, and some people have very, very set ideas about what you should do and what you should not do. So I try to address it somehow, even when I first submit the paper.
So I'm very, like I predicted, we're out of time. But before we let everyone go, so maternal fetal health, environmental impact on neurodevelopment and climate and health, 2, 3, and 4 p.m. upstairs. And sorry, Erica, we didn't get to your question, but hopefully more of a chance. Please, everyone, join me in thanking Dr. Papatheodorou. Thank you. And we're having lunch outside for anyone who can join us at the courtyard. So please come. Thanks for coming, everyone.